meglitinides that are used in the treatment of type 2 diabetes mellitus. Sulfonylureas are older medications that have been used for several years for the treatment of type 2 diabetes mellitus. Some of the examples are glimepiride, glyclazide, glipizide. Meglitinides, on the other hand, are newer medications with a similar mechanism of action as that of sulfonylurea. Both these drugs act on pancreatic beta cells and increase the release of insulin. They act by blocking the ATP-sensitive potassium channels, and closing the potassium channels reduces the potassium efflux, causing depolarization of the pancreatic beta cell membrane, and this depolarization causes opening of the calcium channels, allowing the entry of calcium into the cells and increasing the calcium concentration inside the pancreatic beta cell. So raised intracellular calcium stimulates the secretion of insulin by the pancreatic beta cells. These drugs are known as secretagogues because both these drugs stimulate the pancreatic beta cells to release insulin into the circulation. So this is the similarity between sulfonylurea and meglitinide derivatives. So what are the differences between these two classes of drugs? The main point of difference is the onset and duration of action. Meglitinide derivatives have a rapid onset and a shorter duration of action. When taken orally, it is absorbed into the systemic circulation and achieves a peak plasma concentration within 1 hour. Also, the half-life is very short, which is 1 hour. So, it is eliminated from the body within 4 to 5 hours, and therefore, it has a very short duration of action. Since the drug has a very short T-half, it is administered 3 times in a day. Also, because meglitinide derivatives have a rapid onset of action, they are typically well suited when the blood glucose levels are rising. Therefore, these drugs are administered just prior to meals so as to control the blood glucose levels after meals. So, these drugs specifically target postprandial hyperglycemia. As we know that postprandial hyperglycemia contributes to glycosylated hemoglobin and is also an independent risk factor for microvascular and macrovascular complications of diabetes mellitus. There are very few drugs that specifically target postprandial hyperglycemia. So the advantage of meglitinide derivatives is that it has a rapid onset, shorter duration of action, controls postprandial hyperglycemia, and therefore preferred in a patient who has high postprandial hyperglycemia. In contrast, sulfonylureas are slow acting and have a longer duration of action. Because these drugs have a longer duration of action, they are very effective in controlling and maintaining the blood glucose level throughout the day. Also, these drugs are effective in maintaining the plasma blood glucose level. Also, these drugs can be administered once daily because of the longer duration of action, unlike meglitinides, which control postprandial hyperglycemia and are administered more frequently, about 3 times daily, and it is administered just before meals. So now let's compare the safety profile of sulfonylurea and meglitinide derivatives. The commonest side effect of sulfonylurea is hypoglycemia, which can be profound, and severe episodes may require hospitalization. Hypoglycemia is common with sulfonylureas because the insulin secretion by sulfonylurea is independent of plasma glucose levels. So even if the plasma glucose levels are less, sulfonylureas stimulate the pancreatic beta cells to increase the secretion of insulin, which further reduces the blood glucose levels, causing hypoglycemia as a side effect. So the insulin secretion with meglitinide derivatives is more after the meals when the blood glucose levels are rising. So hypoglycemia less commonly seen with meglitinide derivatives, and it is more common with sulfonylureas. In terms of body weight gain, sulfonylureas are known to increase the weight of the individual, and therefore these drugs are preferred in lean individuals with type 2 diabetes mellitus. In terms of cardiovascular safety, studies have shown that sulfonylureas increase the risk for cardiovascular events. Meglitinide derivatives, on the other hand, have a better cardiovascular safety profile. Also, in case of kidney dysfunction, sulfonylureas should be administered with caution. This is because most of the sulfonylureas are excreted completely through the kidney. So in kidney impairment, such as in chronic kidney disease, these drugs are accumulated and this can lead to dose-related toxicity. Meglitinide derivatives, on the other hand, are dependent on the liver for metabolism. They are not dependent on the kidney for elimination, and therefore these drugs are considered to be safe in kidney disease. So in kidney dysfunction, meglitinide derivatives are better drugs than sulfonylureas because sulfonylureas are eliminated primarily through the kidney. Next is toxic effect on the pancreatic beta cells. As mentioned, sulfonylureas stimulates the pancreatic beta cells to cause insulin secretion. Because of the action of sulfonylurea for a prolonged period, there is injury, apoptosis of the pancreatic beta cells. This causes exhaustion of the pancreatic beta cells. This decreases the effect over a period of time, and therefore these drugs can lead to secondary failure of the pancreatic beta cells. Meglitinide derivatives, on the other hand, have lesser toxic effect on the pancreatic beta cells. So the secondary failure is less commonly seen with meglitinide derivatives. The efficacy does not decrease over a period of time as in sulfonylureas, where they become less effective when used for long term, and this occurs because of secondary failure and exhaustion of the pancreatic beta cells. So to conclude, sulfonylureas are widely used for the treatment of type 2 diabetes mellitus because of its greater efficacy in lowering the blood glucose level, in maintaining the fasting plasma glucose and glycosylated hemoglobin, whereas meglitinide derivatives are more effective drugs in controlling the postprandial hyperglycemia. However, caution needs to be kept in mind when sulfonylureas are prescribed in kidney dysfunction, an exception being glipizide, which is dependent on liver for metabolism and can be used in kidney disease. Also, it should be prescribed in lean individuals. Hypoglycemia should also be a consideration, and precaution should be taken against hypoglycemia, and also the efficacy of sulfonylureas decreases over long term. So thank you for watching. If you find my video useful, please like and subscribe to this channel.